Well, I'm P Yadava. I'm the Chief Cardiac Surgeon and the Chief Executive Officer of the National Heart Institute in New Delhi. Now, this surgery is essentially a kind of an aneurysm surgery. We find whenever a myocardial infarction takes place, myocardial remodeling occurs, and this myocardial remodeling usually takes the form of the LV size gradually increasing, the muscle thickness becoming thinner and thinner, and the diameter increasing according to the Laplace and the Frank-Starling laws which operate in these circumstances. Whenever we do a bypass surgery, the viable myocardium recovers, but non-viable myocardium does not. And some of these patients, they continue to have ongoing ventricular dilatation and adverse remodeling. And that's why in the 80s, ACE inhibitors were introduced to favorably alter this adverse remodeling. Subsequently, it was thought that if the drugs can do that, why not we do this remodeling surgically, and therefore volume reduction surgery was introduced, and a trial called the STITCH trial, surgical treatment of ischemic heart disease, was launched, and initial results showed that it was not satisfactory, but then on detailed analysis it was shown that surgical remodeling is a valid form of therapy and it improves the patient. The hypothesis 1, we compared bypass surgery with just medical therapy, and now 10-year results of the STITCH extended trial are available, in which it has been shown that surgery is far superior to medical therapy. In the hypothesis 2, CABG alone was compared to CABG plus SVR, or surgical ventricular restoration, in which the volume of the left ventricle is reduced. And it was found that those cases where the volume was reduced satisfactorily up to 30% reduction of the volume, then they did extremely well and they got survival benefit. And what was noticed 5 years back as a failure of STITCH trial was essentially due to those patients where volume reduction was not adequate. So currently it is felt that if the patient has a left ventricular end systolic volume index, mind you, I'm not talking of absolute value, I'm talking of an indexed volume more than 60 ml per meter square, then we should go for an SVR. And if the segment of the myocardium is akinetic or dyskinetic, then that should be excised and we should reduce the volume of the ventricle by 30%, and it will give not only mortality and survival benefit, it also reduces the heart failure and the re-hospitalization rates. So it is very important that we correctly identify the patients. So selection of patients is important, and number 2, the procedure is adequately performed. Most of the failures are due to surgeon reducing the volume by a minuscule fraction and not by a mandated 30% reduction in the end systolic volume index.